Yeah. So for those who come in late, I think we decided to do is to see if we can finish up with the endocrine today, so that we're not going to worry about the urinary or renal pathology until next week. But because of the quiz next week, that's going to take some time from us. I'm going to post the introductions an hour or so on the urinary or renal pathology. So please listen to that before you come to class. And so next week, I'm not going to start on the first slide, but I'm going to probably skip all that up to, let's say, congenital. And then we're looking at the renal pathology. Okay. All right. Are there any questions? No. Urinary, you mean, or kidney pathology will not. So the quiz 6, your last quiz, will be only on the endocrine system. Okay. Um, I didn't want it to rush it today because I wanted to take some time to explain. And can it be confusing, particularly Men 3? One easy way to remember Men 3 is to think of them as three M's, right? Or you can say 2M and 1P. If you remember them as 2M and 1P, remember the P here would be pheochromocytoma. And what is pheochromocytoma? We're going to see that a little bit. That's a tumor in the adrenal medulla. Uh, and adrenal medulla put out a lot of epinephrines and norepinephrine. And so in pheochromocytoma will be a patient that certainly have all of a sudden a an increase in heart rate, uh, increasing in pressure, sudden, right? So it could be, let's say, 120, 140. It goes to 200, 240, like that. So that's very characteristic of pheochromocytoma. All right, so we're going to see the three different men a little bit. And just to note that men 1 is 3P, is the pituitary, parathyroid gland, and pancreatic islet cells, okay, or PPP. And then now we're going to look at what are the abnormality of the parathyroid, if you will. Okay. All right, so parathyroid, typically this is the gland that secrete out PTH, parathyroid hormone. And PTH normal function is to increase your blood calcium level. And it does so by either stimulate the kidney to take back um, the, um, the calcium, stimulates the osteoclast to chew up the bone, right, to release this calcium from calcium crystal. Calcium has hydroxyapatite, and to stimulate with vitamin D absorptions of calcium through the small intestine. Okay, so hyperparathyroidism is too much of that, and uh, it is um, the hyperthyroidism. One cause of that, the primary cause, is part of Men1. Okay, so basically, the people are starting to map out where the mutation might be, but it's the mutation in this gene that often leads to uh, multiple tumor in the parathyroid, in the pituitary, and in the pancreatic islet cells, if you will. So, so think of this: Men1 as PPP, okay? And the parathyroid gland, there are 4 glands sit next to the thyroid in the back. It has the opposite functions of calcitonin, right? Which is decreased blood calcium. That's calcitonin, but PTH increases it. In the case of Men1, all 4 gland is affected. Primary cause of hyperthyroidism due to carcinoma is very rare. Parathyroid adenoma, a common cause of the hyperthyroidism. hyperthyroidism. Okay, so this is the tumor within the parathyroid gland. Now you notice that the parathyroid gland has really nothing negative feedback to the anterior pituitary, for example. So in other words, even if you cut someone's head off, right, the parathyroid gland will function normally because it is sensing the amount of calcium in the blood. And then if its blood calcium is low, it attempts to increases it. So it's actually monitoring the blood calcium level, and it has no negative regulation or positive regulation from the anterior pituitary or from the hypothalamus. Okay, so there are different causes of parathyroid gland, secondary cause and tertiary cause. In the case of secondary cause, is usually seen in chronic renal failures patient. Okay, as you know, the what happened is that the people who have renal failure typically has a phosphate retention, right? And phosphate and calcium is usually considered the yin and the yang for me. Okay, so just like sodium and potassium, intracellular, for example, you have a lot of potassium, um, and you don't want potassium and a lot of fast phosphate, and you don't want calcium around because it can form calcium. Therefore, intracellular, particularly skeletal muscle, calcium is usually it's compartmentalized in sarcoplasmic reticulum, for example. Okay, so I kind of diverged in that little bit, but the point here is that in the kidney patients who have kidney problem will have phosphate retention, and they have hyposecretion or hypocalcemia, we call this, and so then the body attempt to increases the PTH to bring up the blood calcium. Okay, so that's secondary. The primary cause of hyperthyroidism, which you can think of, this would be high PTH. Okay? Now, high PTH due to low calcium. Okay? All right, so the common cause would be the parathyroid adenoma, parathyroid hypoplasia, a part of MEN1, and parathyroid carcinoma. Okay, but that's rare. So basically, it's neoplastic lesion in the parathyroid gland. The difference between parathyroid adenoma versus parathyroid hypoplasia is that the adenoma may affect only one of the four, whereas here it's all four might be affected. Right? Secondary is due to renal failure, failure because essentially is that the someone who already have this condition, renal failure, and they trying to bring in a lot of PTH. Therefore, the cells started to proliferate. So we call that parathyroid adenoma occur within the secondary patient. So we call that tertiary. I don't think that's really important. I think maybe just appreciate these two, or more importantly, appreciate that how renal failure patients or patient with renal failure can have hyperparathyroidism. Also, I think the take-home message is to think of hyperparathyroidism as bone, stone, and psychic moon. That's easy to remember. And what this meaning that in patients who have hyperparathyroidism, because PTH stimulates the osteoclast tissue of bone, they generally to have weaker bones, if you will. And because you have your blood calcium is very high, and particularly that goes to the kidney, you can develop kidney stone. So that's common. Fragile bone, kidney stone, and a lot of calciums around could interfere with the normal regulation. Depression, psychotic, depression, that kind of thing. This is in general is known as a psychic moan, maybe headache as well. Okay, so bone stone, psychic moan, think of it as same as hyperparathyroidism, too much blood calcium. As you can see here, we showed you bone resorption, increased calcium, that could lead to kidney stone. Typically, in this case, it's adenoma. Only one of them will have it. But in the case of men, one, then it'd be all four. Okay. Features of hypothyroidism, typically women's in the late stage. Again, lithoisis, basically nephron, litho mean bones. So basically that just means kidney stone. Fragile bone, thirst, polyuria as well. High serum calcium, low phosphate, psychic moan, headache, seizure, and weakness, anorexia, if you will. So hyperparathyroidism, easy bone stone, and psychic moan. Other causes of, on the other hand, hypoparathyroidism, okay, is the opposite of that. Again, radiations and surgery, iatrogenic. Some people are born with low congenital. May be related to Parkinsonism. People have low dopamine release from the basal ganglion, if you will. There could increases heart rate, tetany, neuromuscular irritability. Again, the concentrations of calcium regulate neural activity. Too low, or too much, too low could lead to irritability, if you will. All right. Disease of the adrenal cortex. So basically, we'll finish with parathyroid. Whereas, think of it, hyperparathyroidism, bone stones, and psychic moan. Okay. And iatrogenic radiations or surgery. And in fact, what happened is that it's very, very common that people have hyperthyroidism end up having hypoparathyroidism. Why is it? It's because either surgically remove the thyroid gland and accidentally remove the parathyroid gland. Okay, that's very common too. Okay, so adrenal cortex we talked about already. The adrenal medulla secrete epinephrine and norepinephrine. That's neural. Okay, and tumor in the adrenal medulla and epinephrine will lead to, norepinephrine. Pheochromocytoma. Okay, so pheochromocytoma is a cancer of the adrenal medulla, right? So you can remember them as either P, as in pheochromocytoma, or you can remember them as medullary adrenal, okay? In which case, both of these is considered as part of the MEN3. All right. The adrenal cortex, different zones. You can have either the zona glomerulosa, zona fasciculata, zona reticularis. Any of those layers, the zona glomerulosa is in fact put out aldosterone. can lead to hyperaldosterone or zona fasciculata, give rise to hypercortisone, and that hypercortisolism is related to Cushing syndrome, if you will. Okay, so this is too much hyperaldosterone, and aldosterone stimulate the kidney to take back sodium, so your sodium will be very high. And then we're going to talk about how congenital adrenal hyperplasia is a condition in which the typically, because there is a defect in a enzyme, say cytochrome 451, that is involved in making steroid. So you have a backup of the precursor form and so forth. Now, the females now can started to have high testosterone. And it's not uncommon that in congenital adrenal hyperplasia, that because of high testosterone that can stimulate the clitoris to become very large, like a penis, if you will. I'm going to show you a little bit. Okay, in hyperaldosteronism, it is a tumor in the zona glomerulosa. It's also known as the Conn syndrome. Okay? Idiopathic bilateral hyperplasia of the adrenal gland, adrenal carcinoma, or the secondary to hyperaldosterone is basically renin secretion. Renin is secreted by the juxtaglomerular cell of the kidney. Renin converts angiotensinogen to angiotensin 1, and angiotensin 1 converts it to angiotensin 2. Angiotensin 2 is a vasoconstrictor and also stimulates the adrenal cortex to put out aldosterone. So secondary hyperaldosterone is due to renin hypersecretion. Okay. In the case of primary hyperaldosteronism, is the tumor or hyperplasia, okay, of that layer, the outer layer, zona glomerulosa. This is known as the Conn syndrome. It's basically, in the future, we say, what's a Conn syndrome? That's straight definition. That's primary hyperaldosteronism. So how can you differentiate between primary versus secondary hyperaldosteronism? Does anybody know? This case is easy. It's basically look at the level of renin. Renin is high in one versus renin is low in the other one. Okay. Hyperaldosteronism, of course, because you have a lot more sodium, is the opposite of that, right? You can have hypernatremia. So again, in the volume is the same. You know, let's say this is all volumes of blood is 10 ml, 10 ml, but because you have more sodium retention, so let's say here was 20 molecule of sodium, now it's become 40 molecules of sodium, for example. So in this case, we call this as hypernatremia. Natremia. Now, typically, the way that the kidney, when it takes in sodium, it get rid of potassium. That's the yin and the yang. When it take in potassium, it's get rid of sodium, right? In the case of ANP function, natriuretic peptide, as such, when you have a lot of sodium that comes in, you lose a lot of potassium. So corresponding, you get hypokalemia, right? And that could lead to muscle weakness. Because of low potassium, it can make it interfere with the repolarizations of the membrane, for example. Okay. So elevated levels of aldosterone, low renin, that suggests it's primary. Elevated level of aldosterone with high renin, then that's usually considered secondary, right? So distinguish between primary and secondary is due to the presence of renin. Cushing's disease or Cushing's syndrome, and again, if it's Cushing's disease, it's going to be more of considers ACTH dependent. Okay. ACTH dependent type, you can have pituitary overproduction. We talked about already that's Cushing's disease, right? But in this case, iatrogenic excessive administration. Or in the case of perineal syndrome, we call it oak cell carcinoma, or other kinds of cancer that can put out a lot of ACTH. Pancreatic cell tumor, thyroid medullary carcinoma, carcinoids of the bronchus. How about instead of thinking of all these five, just known as one, okay? The oak cell carcinoma is a good example of a perineoplastic syndrome that could contribute to Cushing's syndrome, in which ACTH dependent. In the non-ACTH or non-ACTH dependent or ACTH independent, in which the ACTH level is low, right? Or what happened is that the typically you're going to have a tumor in the adrenal cortex themselves that putting out these hormones that have high steroid disease, and then typically negative feedback, ACTH will be low. Okay. Overproductions, we already say that Cushing's syndrome, you can have tumors in the lungs, oak cells carcinoma, perineoplastic syndrome. You can have a overactive tumor or even hypoplasia in the anterior pituitary themselves that put out ACTH. So all of this is ACTH dependent, but if it's in the tumor themselves, in the adrenal cortex, you see here, then these would be considered ACTH independent and can sometimes overuse of drug, if you will. Hypercortisolism or Cushing syndrome, we talked about already, moon phase, buffalo home, central obesity, and amenorrhea, if you will. Okay, so these are all signs that are often seen here in this person as well as here. Okay, let's do a couple more, and actually I might finish this in 8 minutes. Okay, now in congenital adrenal hyperplasia is due to the mutation of cytochrome of 450. And in this case, I'm just going to show you here. This is the biosynthesis of the steroid. All the steroids come from cholesterol base. Okay, so cholesterol here, and how cholesterol can give rise to progesterone, estradiol, cortisol, and aldosterone, for example. All the steroid hormone typically produced in the adrenal cortex, also produced in the male testes, in the female ovaries, for example, like progesterone. And you just follow these arrow here, right? And they told you different precursor. You don't have to know all of these different intermediate, but to note that the cytochrome 452 are also known as CP212A, which is this enzyme right here. So in this case, what happened is there's a defect in this enzyme, right? And this enzyme typically, if you see it in the adrenal cortex, who involve and make cortisol. But if there's a mutation here, so now you get this backup of of the intermediate, right? And this intermediate now then can switch over to produce this, right? And the androstenedione of the androstenedione can actually give rise to testosterone, which is an androgen, it's a male, right? So if you look at someone who has congenital adrenal hyperplasia, see this right here, it look like this child is having this thing look like a penis, right? But it's not. It's actually, this is a clitoris. But because there's a lot of testosterone, it stimulates this enlargement like this. And you know that this is a female because this is labia majora here. Underneath is labia minora. This is a female, but how it has ambiguous, I guess you can say external genitalia. This is not a penis. This is a enlarged clitoris, right? That due to too much testosterone, because there's a defect in enzyme that leads to an intermediate that converted to androgenic hormone. Okay, so I still got 4 minutes. Hypo functions of the adrenal cortex, that's Addison disease, we talked about already, and how in Addison disease, this person has this forever tan, and that is because the melanin stimulating hormone is produced at the same time ACTH is produced, because they have hyposecretion of the adrenal cortex hormone, negative feedback. We're trying to increase it at putting a lot of ACTH, but the CTH is defective, whereas the FSH is not. And therefore, this person has this forever tan. Underactivity of the adrenal cortex, adrenal efficiency, we showed you these typically Addison disease, including, but not limited to, eosinophilia, right? Remember we're talking about eosinophilia, NAACP, neoplasm, Addison disease, allergic reaction, collagen vascular disease, and parasitic infection, right? And hyposecretions of the adrenal cortex could be due to typically DIC or shocks, so that's basically could lead to not a lot of blood supplies going to the area. All right, so let me, okay. And the important thing that is the cancers of the medulla is known as pheochromocytoma. Pheochromocytoma put out epinephrine and norepinephrine. This is known as catecholamine, by the way. Okay, it's a mean group of types of hormone. And note, proximal means sudden hypertension. That's the key word. Tachycardia, and you can actually see the tumor, either CT or sono. And lastly, I want to talk about 3 different kinds of men. Men endocrine, multiple endocrine neoplasia is usually tumors that occurs in multiple organs at the same time. There's type 1, pituitary, pancreatic, and parathyroid, all P. All of these men is usually due to increases calcium, increases catecholamine, and increases calcitonin, or all C. Men too are in the medullary carcinoma of the thyroid, pheochromocytoma, or adenoma of the parathyroid. Okay, And MEN3, you can say it's either 3M, the medullary thyroid, the medullary of the medullary of the adrenal, or the mucosal neurema. Or you can say this is 2M and 1P, right? And so lastly, this is it, okay? So this, I'm not going to talk about pancreatic tumor, so you don't have to worry about that. But this will outline for you the three different men. Men 1, men 2, and men 3. Men 1 is known as the Verman syndrome. It's related to the three Ps, are tumors in the pituitary gland, tumor in the parathyroid gland, and tumors in the pancreatic islet cells. So remember, in the men 3, typically within the group, most likely I would say that this is the type of men that often shows either due to increased calcium, increased catecholamine, or increases calcitonin to 3C. And then you have to sort out whether it is men 1 or men 2 or men 3. Men 1 is 3P, pituitary, parathyroid, pancreatic. Men 2 is 2P and 1M, pheochromocytoma, which is the tumor in the adrenal medulla, right? Parathyroid hypoplasia, part of the men 2, and the medullary carcinoma of the thyroid, right? Remember that's 2A. And men 3, which is the 3M, you can say either the mucosal neural syndrome, the parathyroid is rare, but typically it's here is mucosal, medullary thyroid, pheochromocytoma, that's 2M and 1P, or pheochromocytoma is the same as, if you remember at 3M, as medullary adrenal. Okay. Okay, I'm going to end my talks here. Sorry about running out. I will post the 1-hour introductions to the urinary system or renal pathology as well. Okay, are there any questions? I'm going to stop.